Again, my name is Dr. Richard Colgan. I'm a professor of family and community medicine at the University of Maryland School of Medicine. I also serve as vice chairman in our department and executive director of the Mini Medical School program. We hope you enjoyed last week's session with Dr. Gloria Reeves, who presented on managing stress, anxiety, and depression, and Dr. Dominic Williams, who shared information on the proper treatment of burns, bruises, and cuts. A special welcome to those of you who are joining us for the very first time this week. But I know many of you are longtime attendees, and we look so much forward to seeing you back again. And I know you're going to enjoy tonight's program. This evening, you'll be hearing from two of our esteemed faculty members. But before I introduce our speakers for the evening, Ms. Robinson will share a few housekeeping items and reminders. Ms. Robinson.
Thank you, Dr. Colgan. Again, welcome to week 3 of Mini Medical School. Let's quickly review a few housekeeping items and reminders. Everyone should already have the link to the electronic course materials. And if you go over to the week 3 folder, you'll be able to find our faculty bios as well as a copy of their presentations. We will be uploading the faculty presentations weekly, so please be sure to check the folders before the course in the evening. In addition, kindly remember to complete the individual course evaluations at the end of each presentation. I will insert the survey link in the chat box during our brief intermission this evening. So please be sure to use today's link to evaluate today's presentation. And then also regarding attendance, please remember that graduation certificates are only given to students who attend 4 out of the 5 classes. So please be sure to log in each week. And as a reminder, we only know you're here if you sign in with the email address you registered with in Zoom. Now, regarding questions, we will be taking questions at the end of each discussion. Our presenters will spend the last 5 to 10 minutes of their sessions taking your questions. Please insert your questions in the chat box while the presentation is in session. Or if you prefer, you can ask your questions audibly in one of 3 ways: by phone, by computer, or by using your app on your tablet or phone. Thank you for your attention. And now Dr. Colgan will introduce our first speaker for the evening.
Thank you, Lauren. It's my great pleasure to introduce Dr. Justin Price. Dr. Price is an assistant professor of hospice and palliative care in the Department of Medicine at the School of Medicine. He earned his medical degree at Morehouse School of Medicine in Atlanta, Georgia, and completed a residency in internal medicine at Johns Hopkins Bayview Medical Center. He completed a fellowship in hospice and palliative care at George Washington University in Washington, D.C. His clinical interests include palliative care and symptom management in early and advanced cancer. Here to present on chronic pain management, Dr. Justin Price.
Thank you so much, Dr. Colgan. Thank you so much. Thank you so much for having me this evening. I'm so excited to be here. I saw a message in the chat. Someone said they couldn't hear. Can everyone hear me? Can everyone hear me? Yes?
Yes.
Oh, perfect. Okay, I saw that in the chat. I was like, wait a minute. Okay.
Yes.
All right.
Yes.
Wonderful, wonderful, wonderful. Thank you so much. Great, great. So I'm so excited. So what I'm going to talk about today is a topic that's really near and dear to my heart, and it's palliative care. I'm gonna add in a little bit of talk a little bit about pain as well, and how that relates to palliative care. Let me see if I can do this correctly here. All right, share my screen. And then I don't want to do this. Go back. Okay. Let's see. Okay, can everybody see my first screen? What is palliative care? Excellent. All right, I'll get started. So, it's funny, interesting. I was talking to some of my friends yesterday about my talk, and I said, I'm gonna talk about palliative care, and some of them started looking in their phone, trying to Google, like, what is that? So it's very common that a lot of people aren't sure what is palliative care. So I'm going to introduce palliative care tonight, and also I'm going to, and as I mentioned, I'm going to talk a little bit about pain and how that relates to that. So I have no disclosures today. Someday we will all die, Snoopy. True, but on all the other days, we will not. And what I want to talk about today is how we live. So what are the objectives today? Well, I want us all to understand what is palliative care. I want us to improve our knowledge on what services palliative care provides, and improve our knowledge on how we treat pain in palliative care. And I also want everyone to gain an understanding about what is advanced care planning and why is it important. All right, so I'm gonna start with a pop quiz for everyone. Let's see who gets this right. Which of the following people would benefit from palliative care? So is it 1, a 51-year-old man who recently had a heart attack? Is it 2, a 35-year-old lady with a new diagnosis of breast cancer? Is it 3, a 74-year-old man with advanced prostate cancer? Or 4, a 60-year-old lady with congestive heart failure who has been admitted to the hospital multiple times in the last year? Or 5, a 40-year-old healthy man with chronic kidney disease? You can choose one or more answers. What do you guys think? Maybe put an answer in the chat if anyone is open to doing that. Okay. I don't think I have access. Oh, I see 9 up here. I don't think I have access to the chat. What are some responses we're getting here? Lauren, do you mind saying?
Yes, I'm so sorry you can't see the chat. That's no problem. So we are seeing number 3. We're seeing number 3 and 4. We have a few responses with yes, all.
Okay.
A lot of 3 and 4s and a lot of alls.
Excellent. All right. That's good. Excellent. Okay. So the answer is all of the above. That is correct. And I'm going to talk today, and hopefully at the end of the talk today, that you'll see why all of the patients I outlined, the examples I gave, could benefit from palliative care. Now, this is a strict definition. No one needs to be alarmed. I'm explaining, I'm going to break it down throughout this presentation. But how do we define palliative care? Palliative care is a specialized medical care for people with serious illness. It is focused on providing patients with relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve, and I want to focus on that word right there, quality of life for both the patient and their family. Palliative care is provided by a team. So we're a healthcare team. Even our team here at the University of Maryland, we have a whole team designed to help patients and, of course, help their families as well. And that team includes doctors, nurses, and other specialists who work together with the patients, other physicians, to provide an extra layer of support. And I always like to introduce myself when I'm meeting a new patient or a patient's family member that we're an extra layer of support. And we're appropriate at any age, at any stage in a serious illness, and can be provided along with curative treatment, which is important too, because sometimes with palliative care, people misassociate or misinterpret or have a perception that when we walk in the room and I say I'm a palliative care doctor, that equates to end of life, and that's not correct at all. In fact, palliative care can be beneficial at any stage, and of course can be along with curative and even aggressive treatment. Because as we continue on this talk, I want to know that we really emphasize, as being an extra layer of support, communication. So communication about someone's illness, communication about what their prognosis, communication about what their goals are, communication about, if they're unclear about what a specialist is recommending, talking more about what's most important to them. And so we try to provide a communication about whatever issue it is that they're facing. And so that can be useful at really at any stage in someone's illness. Quality, you're going to see that as a theme throughout my presentation. We want to have people have the best quality of life regardless of what stage they're at in their disease process. Palliative care is not end-of-life care, but end-of-life care is a part of palliative care. So they are not equitable. End-of-life care and end-of-life care is just that, end-of-life care. But palliative care is something that can be useful even at the beginning, or when someone is first diagnosed or has a serious illness in the beginning, even when people are feeling well. As I talk throughout this presentation today, I'm going to outline how we do that. Yes, early palliative care is proven better, like before it hits 4:30 on Friday. I like this schematic here. What has been known about palliative care? Well, we know that it improves quality of life for patients. How do we do that? Well, we do that, one of the ways we do it is by improving symptoms. And studies have shown that we reduce symptoms by up to 66%. And we also improve patient satisfaction in regards to their patient experience. And we have good evidence of that in the literature as well. Because when you're overwhelmed with symptoms, whether it's pain, shortness of breath, anxiety, feeling agitated, and these kinds of symptoms can certainly affect your quality of life. And so I think our contributions are twofold. One, of course, is symptoms, we're discussing now. And next, as I continue to talk, we'll talk about our communication and advanced care planning that we provide. What more can we talk about in regards to palliative care? Well, we're talking about good medical treatment. I use the word good, not because people don't offer good medical treatment, but is this treatment that's not only effective, but is it aligned with what you want and what your goals are for your care, though? So I think good medical treatment is targeted to what works for you as the individual. That's what I try to target when I'm meeting a patient and a family member. Never being overwhelmed by symptoms. Planning ahead, no surprises. I love this next one, customized care based on personal preferences and values. What are your values as an individual? What are your preferences? What are your goals for your care? That's what we're going to focus on. Yes, it is important to know what your laboratory values are. It is important to know what your blood pressure is. But we're going to focus in a different way on your care. We're going to have customized care. We're going to involve your family. We're going to make the best out of every day. This came from Joanne Lynn, who works at GW. She's actually a pioneer in palliative care and a pioneer in living better, regardless of whatever your illness is, getting the best quality of your life. She's a very, very, very prominent member of palliative care and very respected. So how is palliative care helpful in patients who have a serious illness, particularly if their illness becomes more advanced? So we focus and our aims are to relieve suffering, improve quality of life, because as people approach the end of life, as their bodies are changing, as they begin to transition, their needs, their symptoms change. They have more needs. They do experience discomfort. They do experience pain. There is shortness of breath. There is anxiety. There is agitation. And so as palliative care physicians and palliative care team, we address these things because these are tied into someone's quality of life. We also tie into a quality of life in regards to making sure that the steps we're taking are aligned with what they view as quality of life. For example, someone might say, you know what, my quality of life is not necessarily being in a hospital setting. It might be, I feel like I tie my quality of life for being at home with my family. And so we're gonna see that as a goal, and we're gonna work towards trying to, how do we achieve that? What steps can we take in our plan of care to be able to help to achieve that? That's just one example. Communication, communication, communication. I just think that's critical. That's a family meeting today, and I was teaching one of our medical students that my whole purpose of going to the family meeting and be a participant was to make sure there was open communication between the family and the medical team. And every question I asked was centered around communication. Are your questions answered? Tell us what your thoughts are. Even though the team's focus was, you know, this is what the CT scan showed, and this is what the chest X-ray showed. But when as I was involved in the family meeting today, my focus was different. This is what we focus on. So even though the patient was very ill, this is really important. This is how palliative care can be helpful. Understanding illness, prognosis, treatment options, and treatment trajectory. You know, oftentimes there's mixed messaging sometimes from some of the specialists. They're doing the best they can, but sometimes it's hard to kind of be able to really have a true understanding of what your illness means or what the disease means and what it means for the future. And we like to sit down and have a conversation and talk about it and try to make sure there is a level of understanding, and just make sure that whatever the plan of care that specialist is offering you, that is something that you want and also is going to meet a goal that you're looking for. Because sometimes the treatments that we offer are only to prolong your life, not necessarily to give your life quality. We want to try to distinguish between the two and make sure that that person understands that. This is a healthcare team. So we have a chaplain here as well who will provide spiritual support. And I had another patient today that I called Deborah as our chaplain to come in and not only pray with the patient, but also be a support for the family. So we have a holistic approach. We also have a social worker that helps coordinate in regards to equipment, but also transition too. For example, some people want to get to a specific skilled facility or a specific assisted living facility, or, hey, I'm just trying to get home. And so we have a whole healthcare team that can help navigate through that. Who needs palliative care? Well, I used to have a slide where I said everyone, and I kind of took it down because it's not true. That's not necessarily true. I kind of believe so personally, but that's not actually true. But I think a lot of people can benefit from palliative care. Yes, sure, people with lung cancer, neurological diseases, lung disease. And again, I want to emphasize that really at any stage, dementia, frailty, heart disease, any solid organ disease, so liver, renal patients, lung, heart, chronic kidney disease. So not just end-stage disease, but also chronic kidney disease. And in fact, patients of all ages with any diagnosis or stage of illness could benefit from palliative care. And hope as I go through this talk that that's becoming more clear. Even if someone gets diagnosed or has an illness and they feel wonderful and they feel perfect, which is wonderful, we can still be a benefit. Palliative care can still benefit from whether it's communication, whether it's guidance, whether it's helping connect with different specialists. There are a lot of different ways that we can still be beneficial, even when people are feeling well. Because there are guidance that need to be made about the progression of whatever that disease or disorder is. This is something I think is really critical and really important for older adults. I think we call it the 4 M's. And this is more in geriatrics. It goes more along with geriatrics, but I think it's really important for for our care. This is actually essentially, it kind of gives clinicians more of a roadmap. We called the 4 M's. And this was an initiative that was started by the John A. Hartford, Foundation and the Institute for Healthcare Improvement. And this is evidence-based for a better outcome for older adults and older people. It really provides a framework, a roadmap when we're addressing older adults. And the 4 M's are what matters, mentation or mind, mobility, and medications. And in fact, when I see my patients in the hospital, I have these 4 things listed on my paper because I'm looking and I want to make sure that I'm addressing all of these issues. Because it's been evidence-based that these are things that have found to be most important to older adults. And let's break these things down. What matters? What do we mean by that? Well, what matters to that older person? So we need to know and make sure that we're acting on each older person's specific health outcome goals and care preferences to provide true person-centered care. I just think this is critical. You know, when I sit down and I'm teaching some of the fellows and the students, I tell them, you know, it's important to get to know someone better. It's important to sit down and understand where they're coming from. It's important to sit down and find out what they're hoping for and what their goals are. Find out what matters to them and make sure that whatever plan of care that we're creating, it's aligned with that. Too oftentimes we're coming in and giving recommendations and instructions and we haven't found out, well, what's actually important to the patient or their family. Doing advanced care planning for older persons that identify values, life goals, and preferences. Now I'm gonna talk a little bit more about advanced care planning because advanced care planning can be challenging, particularly when we feel well. I mean, who wants to talk about what they want in regards to healthcare when they might feel ill, or think about a time in the future where they might feel ill? Who wants to think of that? That's a hard thing to think about, or think about a time where they could be very sick. But this is important. And I'm going to explain a little bit why a little bit later in the talk, about why I think advanced care planning is so important. Clarifying an older person's code status. Code status, just to explain for everyone, is when someone's heart is unable to support their body, or it stops, or their breathing becomes labored. I consider it to be one procedure. It is one procedure where we do, if someone's heart were to stop, we do chest compressions, we call that CPR, or we take over their airway using a breathing tube, we call that intubation. And those 2 things tied into what we call code status. And something that commonly we ask patients when they come to the hospital, what is your code status? Would you like for us to do CPR? Would you like for us to do intubation? And that certainly is important. I think it's more important about what is our goals of care. I think that's more important than code status. Because is our goals of care for prolongation, or is our goals of care focused on more comfort focus, or are we doing what we call goal-directed therapy, where we're doing active, full aggressive treatment? But to be clear about code status, that's something that will be asked, and oftentimes it's something that would need to be clarified, particularly in somebody who has an illness that is progressing, and you think that there's a predictable likelihood that they could have a cardiac arrest or stop breathing. And that's something that would be up to the individual. And oftentimes I try to counsel patients when it comes to code status that particularly if it's clear from our science that doing CPR, doing intubation would not achieve a goal that they would be hoping for. For example, if their goal is, I would like to be able to return to the state that I am right now, or I'm expecting that I'm going to be able to be in my right mind if these events were to happen. And I try to explain based on the science, depending on what their health situation is, if it's clear to me that by doing CPR or intubation would not allow them to achieve their goals or be of a true benefit for them, then that's why I recommend that they should be what we call DNR or DNI, which means do not resuscitate, do not intubate. It's not because we're trying to withdraw care or withhold care. It's because we're not trying to provide care that we believe is not going to be effective. That's how I try to explain it. And of course, the last one I have is providing older person with an advance directive. That's a legal document that I give often here. It's a legal document. And some people think, was that a living will? Well, a living will is a part of an advance directive. But advance directive asks more specific questions than just, what would you like in regards to naming that person who would make healthcare decisions. Advance directive asks more specific questions. For example, if you happen to be on life support and it was clear that you would not be able to come off it, what would you want for your healthcare? Or if it was clear that you were declining and there was limited interventions or limited opportunities that we could do to try to stop the progression, what would be your important goals? So the advance directive asks more specific questions than just who would be the medical decision maker for you if you were unable to make decisions, or what would be your code status? It asks more than that, and I'll talk a little bit more about it in a few moments here. Mentation, that's important for older adults. Maintaining the mind. Oftentimes, yes, dementia is a part of that, but particularly as we get older, we're more likely or more susceptible to delirium. Delirium is an altered state of mind and is often caused by sometimes medications, sometimes infection. So we want to make sure we're focused when we're looking at, when I'm looking at an older person, to look at all their medications, make sure there's no medications that can cause changes in the mind. Make sure that there's no infection or things of that nature that could be affecting the mind. Depression is also very common. So we want to have that on our mind too, to try to identify that and treat that as well. And of course, it's important for adults to assess the capacity to make decisions. Because if somebody doesn't have capacity to make decisions, then we should be speaking to another family member, whoever's appointed, to make decisions for them. So we want to make sure that we're taking steps that are aligned that's best for that person. And so we want to make sure we assess capacity. And then the last one was mobility, functional status, moving, exercise. This is so important as we get older. But we also want to maintain our functional status. And we want to make sure that we assess risk for falls can be debilitating. Suffering falls can lead to fractures, which can certainly lead to difficulty. And so we want to make sure that we're assessing these things. We'll make sure if there's a need for assist devices, like a rolling walker or a cane. We want to make sure that if someone needs physical therapy, they get access to that. So mobility. So these are things that has been proven to be important. And then the last one was medications. This is critical. Medications are so critical. Sometimes that's why people are in the hospital, because of their medications. Medications need to be continually looked at, continually evaluated, particularly as people grow and get older or their disease changes. Maybe the medication they're giving them is not as effective anymore. Maybe the medication that we're giving is causing changes in the mentation, changes in the mind. Maybe the medication, maybe we're adding medications and they're interacting, causing adverse effects. And we want to make sure the medication we're providing are, of course, providing benefits, symptom management, improving quality of life, doing what we think, what they're supposed to be doing. This is something that needs to be consistently assessed and reassessed. We want to avoid something called polypharmacy, which is a fancy word for saying, wait, there are too many medications on board here. Let's try to simplify. The 4 M's, really important. What matters? What matters to that person? Let's protect the mind. Let's keep them moving in a safe way. And let's make sure all their medications are appropriate. This is what palliative care can do. Symptom management. I want to get into some symptom management as well. And I'll talk a little bit about pain. I mentioned some other symptoms here because we address these as well. Shortness of breath and constipation. I mentioned increased secretions, but that's more towards the end of life that we focus on that. I mentioned already anxiety and agitation, and of course we nausea, vomiting as well. We really focus on symptom management because it's very tied into people's quality of life. Let me transition a little bit to pain. I want to talk about pain. Pain is a result of both tissue damage and complex psychosocial spiritual factors. What does that really mean? It just means that there's physical pain, but there's also spiritual component of pain. There's a psychology that plays into pain. And so pain, not all pain is treated with pain medications. I think that's the moral of that line. Acute pain is self-limited, usually resolves within 3 months. Chronic pain is pain lasting more than 12 weeks. And there is evidence that quality of life and survival are linked to early and effective palliative care, including pain management. And the goal of pain management is to relieve pain to a level that allows for an acceptable quality of life. You know, sometimes we can't always get someone's pain from a 10 to a 0. You know, sometimes the best we can do is to a 5. Because some of the pain treatments we provide, they have side effects. But the key is trying to find out what's an acceptable pain level. What's an acceptable pain level so someone can still have their quality of life. I love the approach of not all pain needs to be treated with medications. So there are physical and psychological approaches, hypnosis, relaxation exercises, massage, music therapy. That's one I really like. I like all of them, but I really like that one too. Music is close to my heart. I love music, and we have a service that comes and can provide music at bedside sometimes, and that helps a whole lot of things, not just pain, Physical activity, physiotherapy, respiratory therapy, food provisions that can help with pain, and psychosocial support. So there are a lot of different ways to treat pain without using medications. I think this slide right here, when it comes to pain, I want to bring this to everyone's attention because I think this is probably the most critical slide when it comes to pain and pain management. And the reason why is because this comes from the World Health Organization, and it emphasizes a stepwise approach to pain. Pain management is dynamic. It's not one size fits all. It does take, you start with you have to have an evaluation, and then you use, this is what's called the stepwise ladder, where you start with the base, 1. We use non-opioids, and I'll talk about opioids a little bit later. We're talking about our non-pharmacological approaches. We're talking about things like Tylenol, non-steroidals. We're talking about level 1, starting there as an approach, not just starting at a high level with opioids. Let's start there, depending on what pain we're treating. Start there. Then now we go up to level 2. Now we're using more of the weaker or milder pain medications like codeine, tramadol, even low-dose opioids, low-dose morphine. Of course, we're going to use adjuvant treatment. When we say adjuvant, we're talking about some of the non-pharmacological things, like lidocaine patches and diclofenac, topical diclofenac topical we put on like arthritic knees and things of that nature. Non-adjuvant treatment, non-opioid treatment. And then if that's not working, then we go to the 3rd level where we're talking about more opioids. So morphine, oxycodone, hydromorphone, fentanyl. The key to this, why I think it's so important, is it's a ladder approach where we're starting, depending on what the pain is, and then we're gradually increasing based on what the need is. So non-opioid pharmacotherapy, so non-steroidals, and let me emphasize too for everybody that's listening, it's important as you get older, non-steroidals also can affect the lining of the stomach, so they can lead to bleeding. So you gotta be careful about non-steroidals. Make sure you certainly talk to your doctor about it. Tylenol is one that we use quite a bit as an adjuvant treatment. Very useful, very helpful, particularly if you use it scheduled. So, you know, oftentimes we'll use it, people will take, okay, I'll take a Tylenol, you know, or take one or two, but there are times, depending on what pain we're treating, where we'll give it scheduled 3 times a day, 1,000 milligrams. And that can get pain under better control. So Tylenol is a good choice to think about. Anticonvulsants. So gabapentin and pregabalin they're great because sometimes pain isn't always bone, tissue, muscle, things of that nature. Sometimes pain can be nerve pain or nerve component to it. And so gabapentin and pregabalin, which are Neurontin and Lyrica, they can help treat more nerve pain. So we use that commonly as an adjuvant to other pain medications like opioids. Antidepressants. So you think, how can antidepressants? Well, I mentioned before, there is some, can be certainly some psychology to it, but even outside of that, particularly one that comes to mind is duloxetine, which is an antidepressant, but it has properties that treat neuropathic, I'm saying neuropathic, but what I mean for everybody so everyone can understand, I mean nerve pain. And so duloxetine is one I use a lot. It's very, very good. It's able to take away the antidepressant portion of it. It's able to treat pain and treat it in addition to opioids or other pain modalities. Steroids, we use topical, steroids can help in a variety of different ways because oftentimes, particularly when we're talking about our cancers, there's a lot of inflammation around cancers, particularly advanced cancers. And so we'll use pulse doses of steroids to help as well. That's a very good adjuvant treatment. I'm using the word adjuvant, but what I'm trying to say when I use the word adjuvant is I'm saying additional treatment to like an opioid. And then local anesthetics and topical agents, as I mentioned, like a lidocaine patch, which you can slap on and people can get local relief. And I just want to talk about opioid therapy. I just want to emphasize a couple things before we go to the talk about some advanced care planning. As palliative care doctors, we emphasize the fact that our training is about opioids. And there's a lot of misconceptions about opioids. And we make sure we use the right amount of opioid at the right time with the right frequency. And I constantly, even the healthcare teams too, like, of course the patients, because of the misconceptions, try to reassure people that we're using opioids in the right way, and that's why they're beneficial. And they are the cornerstone for moderate to severe pain. And these opioids can be, I think, with better education and people having a more understanding, I'm talking about actually even our healthcare providers. Some of them have misconceptions about opioids. And so that's why as palliative care being involved, I feel a sense of pleasure and gratitude to be involved, because there are times when I feel moral distress because I see somebody that's suffering in pain and discomfort and people are afraid to provide opioids or provide a pain regimen. And so it brings me pleasure to be able to be a participant and be able to provide that for someone and to improve their quality of life and to relieve their symptom burden. We do have to be aware of side effects from opioids. They can cause nausea and vomiting. Hope everyone understands that that's something that's usually an initial response to opioids. And after someone's been on them for several days, this is actually something that resolves themselves. I've highlighted constipation because that's the most common cause side effect from opioids. So when someone is taking an opioid regularly, I automatically make sure they're on a laxative because it so commonly causes constipation. The other ones listed, pruritus, can cause some itching. It certainly can cause some drowsiness and confusion. And we hope to, as palliative care doctors, to try to clear the misconceptions about opioids. Now, can opioids be addictive? I'm sure that the people listening to me might know somebody have heard about that. Can they have harmful side effects? I'm pretty confident that someone listening to me probably has had someone who's had a negative effect from opioids. Can they be dangerous? The answer to those three things is yes, but I want to emphasize that these are drugs that are very useful, very effective, and very safe when they're used properly. That's the key. So what opioids do we use? Well, we use tramadol. I think you guys saw on the ladder that I mentioned. That would be more on the second. That's a weak opioid. We start going up the ladder a little bit. We use morphine. That's a common one. Hydrocodone is a more weaker opioid. It's similar to morphine. And then hydromorphone, which is Dilaudid. We also use longer acting opioids like MS-Contin, OxyContin, and fentanyl. Some of you all might have used some of these medications. I highlight them because, you know, particularly when someone is beginning to has advanced disease. So initially, when someone's early in their disease, we're going to use as needed, shorter acting opioids. But as people get more advanced in their disease, particularly if they're having consistent pain, now we want to use longer acting opioids. Well, what do I mean by longer acting? I mean, you're going to have a pain relief over at least 8 to 12 hour period versus a shorter acting, which is only about 2 to 4 hours. So if someone's having consistent pain that is progressing, we want to make sure we have a longer acting pain regimen on board, but then we will still provide them with shorter acting in between, so they have what we call breakthrough. So if they're still having pain, they have a pain medication that they can take, even if they're on a long acting opioid. So that's one of the ways that we treat when it comes to advanced disease. And there's this old adage in geriatrics, start low and go slow. So we always try to start low and then titrate as needed, go up as needed. So morphine's lowest dose, 7.5 milligrams. Hydromorphone, usually we start with 1 milligram. Oxycodone, 2.5 milligrams, and then hydrocodone, 5 milligrams. And I just have this to illustrate kind of in general, how we start. Particularly, I use the word up there, opioid naive, and that means somebody who just has not taken pain medication on a consistent basis. Somebody who we consider to be opioid tolerant is taking a certain amount of opioids for a 7-day period straight. And so we want to start low because we want to try to minimize side effects. That's why we do it. And this schematic was just up to just show that there are a lot of different choices we have in hospice and palliative care. I should say specifically palliative care. We have a lot of options. There are a lot of ways that we can ensure people have comfort and good quality and have their symptoms relieved. And I just want to emphasize the one on the bottom right. I think everyone can see it. I just highlight it real quick, the methadone. Just want to highlight that real quick because methadone is something that also has a lot of misconceptions and has a lot of misconceptions, but it's one that we use quite a bit, particularly in advanced disease. And it's one that provides long-lasting, effective pain relief. And I've had a lot of success with it. And I just wanted to highlight it this evening so that everyone's not, no one is, I want to try to break the misconception about methadone because it's been tied to, and yes, it is used for people who have an addiction to opioids, but we use it very frequently in palliative care. All right, and I touched a little bit about constipation. And the reason why I just bring it up is that just to ensure that everybody should take a laxative if you're taking consistently, taking an opioid. And usually our first line that we use is Senna. And our second line agents usually use polyethylene glycol, which most people would know as Miralax. We don't use Colace though, because our studies show that that's not effective, even though that's a common one that people use. All right, so I'm coming down to the conclusion here, and I want to talk a little bit about advanced care planning. Advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding their future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during a serious and chronic illness. I just think advanced care planning is so important. And this is something that I consistently ask patients when I meet with them and their families. What is most important to you? What makes you the most happy these days? What concerns you the most about the future? We consider this in palliative care to be the 3 magical questions, because this gives us insight into, similar to the very, very detailed definition I gave of advanced care planning. What is your goals and values? What is most important to you? What does quality life mean to you? What's going to give you the best quality for whatever time that's left? And when we do advanced care planning, we're talking about what kind of care do you want in the future? And we ask these difficult questions. And as I mentioned earlier, sometimes these questions are difficult, particularly if you're, hey, I feel great, Dr. Price. I feel wonderful. Why you talk to me about these issues? Well, I think it's important. I'm going to talk about selecting a healthcare agent. That would mean that you would select somebody who would make decisions for you if, for God forbid, you were unable to do it yourself. If you were so ill, you could not do that. This is important. And then in addition to the healthcare agent, you should talk to whoever that is, whether that's your spouse, a child, a parent. Talk to them about what your wishes are, what kind of care you want. Do you want to be in the ICU if you needed to be? What are there particular surgeries that you would be interested in or not? You know, what if you needed a feeding tube at some point in your life? So we start asking these difficult questions. And as part of advanced care planning is, of course, the advanced directive, which I kind of mentioned a little bit earlier, and looking at decision-making capacity and I use the word healthcare proxy, but what I'm saying is selecting someone to make medical decisions for you and be able to summarize the wishes that you have for your care. Now, this is just the first page of the Maryland Advanced Directive. And again, I want to emphasize this is just the first page. But it allows you can see on the first page where you would select a primary agent. You also can select more than one as well. So you can select many agents if you want to. But as I mentioned earlier during the talk, that this will ask more detailed questions in regards to what it is you would want your care to look like, particularly if you were to become more ill. It even includes things like dialysis. And like I mentioned, feeding tubes. If you are on the ventilator, how long would you want to be on it? So it asks a lot of detailed questions. That's why I think the advanced directive is so important. I only have a few minutes left. I just want to say this one piece. One of the reasons why I emphasize the advanced directive is because I've had scenarios in the hospital where someone is very ill and I go to that family member's spouse, excuse me, the patient's spouse. I'll go to the patient's child or whoever is named as their decision maker. And I'll say to them, and this has happened many times, I'll say, what would you like, what kind of care does your family member want? Do they want this? Do they want that? Have you discussed it? And I can't tell you the look on that person's face when they say, no, I have not had a conversation. We have not filled out an advanced directive. I don't know what they want. Because I'm going to be asking some very difficult questions. Do they want us to continue with doing CPR intubation? Do they want a feeding tube? Do they want us to continue to try to pursue treatment for their cancer at this time? They're on the ventilator and it looks like they're not going to come off, and it looks like they might need to get a procedure like in order for them to stay on it. Do they want that, or do they want us to just focus on their comfort at this time? What do they want for their care? And it's always it's disheartening for me, or challenging for me. I have distress when I'm talking to someone and they have no idea. And that person, that family member that's right there, they're going through a lot of distress because they don't know either. And they want to make a decision that's what that patient wants. So that's why I think advanced care planning is so important, and palliative care can provide that. All right, and so this is my conclusion. Just really quickly, with our pop quiz. So the gentleman with the heart attack, how could we help with this gentleman as part of our pop quiz? Well, we would talk about him in regards to any additional procedure he might see in the past. You know, if he had coronary disease, he might need a bypass surgery. He might need an AICD. When people have a heart attack, you know, they're at risk for having a cardiac arrest. Would he want CPR? Would you want intubation in that setting? So we would talk about what would be his preferences, provide an advance directive. What about a young lady 35 with breast cancer? How would palliative care help with that? Well, we discussed, you know, what's an acceptable quality of life, particularly if your condition were to worsen or if the treatment we were giving were not effective. You know, we talk about symptoms that they could experience. How can we best treat them in the future, these symptoms? You know, what are some treatment options that you could be looking at? We talk about it, an advance directive. What about a 40-year-old gentleman who has chronic kidney disease? How can we help with them? Well, we talk about what about the potential of dialysis and what does that mean to your quality of life? You know, well, would there be a point that you would want to stop dialysis? We would discuss all these things. What are your future preferences? So as I outlined, for the sake of time, I moved through a few of the questions, but there are a lot of ways that we can be effective in their care. So summarize, palliative care is not the same as end of life. It is appropriate at any age, at any stage in a serious illness, even if being provided along with curative treatment. I hope I was able to explain that this evening. Certainly a stepwise approach to pain that's either acute or advanced. Always take a laxative if you take an opioid. And I believe everybody, including myself, should have an advance directive. I did have a couple websites here that you can actually go in and they'll ask certain questions for you. So getpalliativecare.org is one of them. And so getpalliativecare.org. And the other one is prepareforyourcare.org. That's another one, prepare. And if you go on the website, you'll see they'll ask specific questions and about the future and things you will want for your care. So getpalliativecare.org and prepareforyourcare.org. All right, those are my references. Thank you all so much. It's been a pleasure. Are there any questions I can answer?
Yes, Dr. Price. So we did have a few questions that came over in the chat.
Sure, absolutely.
During your presentation. The first one,
yeah, go ahead.
Does your health insurance cover palliative care, Medicaid specifically?
The story about late 2019.
Oh, somebody talking. Yeah, the answer is yes. The answer is yes. Hospice, though, hospice specifically is a insurance benefit. Hospice is. So palliative care, the answer to your question is yes, but it's certainly in certain circumstances. Hospice specifically is a insurance, is a health insurance benefit. Palliative care, I would certainly check on it, but it can be, absolutely, for the most part.
Thank you. And then our second question, what if you get to level 3 of pain management, but there are no improvements with the pain? So
that's an excellent, all these questions are excellent. So keep in mind, those levels are more instructed on when to use more advanced or more aggressive opioids, okay? And so when you get to level 3, I showed it kind of quickly because I was running out of time, but I want to assure you that there are a lot of options in regards to improving pain. And so the levels were more to try to provide a guideline on how to approach pain. There's more of approach to it. I would look at level 3 as saying, okay, I have advanced pain. How can we manage it? Well, there are a lot of different ways that we can manage pain. And I gave some examples with different opioids that we use. I used example of some long acting and short acting, but there are other ways to do it. So there are things that, let me give just a couple examples if I could. So we can do something called nerve blocks, where the interventional radiology can go into specific areas and numb that area where you're having pain. That's just one example. There are certain procedures that we can do depending on what the condition is. There are surgical interventions we can do that are part of the realm of palliative that can help alleviate pain. If people have specific cancers, right? Radiation is something that helps with pain. So my point is that when I said the levels, I was really trying to show everyone that there are guidelines and are steps to how we approach pain. But when you get to a level 3 of pain, there are a lot of different options and a lot of different ways we can treat it, not just with medications, but also other interventions we can do that I've outlined.
All right. Thank you for that response, Dr. Price. We have maybe time for one more question. If there are any more questions, if you just want to unmute yourself and call out, we can probably take one more question before we break before our second presenter.
I have a question. What about medical marijuana for chronic pain?
Yes, so yes, that is something that, now I'm not certified to use medical marijuana, but medical marijuana is certainly something that is effective in treating pain, excuse me. It's something that's actually really becoming more and more prominent. It's accelerating and just in general in the field and its use. And to answer your question, it certainly is effective. And there are, I know certainly some palliative care physicians that are utilizing medical marijuana. I am not certified to use that, but there are, and it is effective, and people are getting a lot of benefit from it. Absolutely.
I had to put my teeth in.
Oh, sure, excellent question. Yeah, is there time for one more?
Yeah, we have time for one more.
Okay.
Takers. All
Well, I can do a comment. I see someone just wrote, just completed my advanced directive. It was a free program offered through UMB Community Engagement Center. Oh, that's great. And you know what? I want to add one other thing too, everybody. So when you fill out the advanced directive, it can be changed. It's not set in stone at that moment. It's something that can be changed. So particularly, it's like I mentioned earlier, it is challenging, particularly early in a disease or when you're feeling well, to really know exactly what you want. And so particularly as things change, you know, what your goals and values might change. So it's something that, yes, it's a legal document, but it is something that can be changed as well.
right, that's great. Well, Dr. Price, we thank you for your time this evening. We thank you for joining us. I know that we all thoroughly enjoyed your presentation.
No, thank you for having me. It's been a pleasure to be with you all this evening. It really has been.
Absolutely, absolutely. All right, well, we will now take a short break. We will resume at 7:05 with our next speaker. So this is a great time to get a sip of water or stretch your legs. We will meet back up in about 7 minutes. Thank you very much.
Welcome back, everyone. We'll now hear from our second presenter for the evening, Dr. Emerson Wickwire. Dr. Wickwire was an associate professor at the School of Medicine within the Department of Psychiatry and the Department of Medicine, but he has, I just learned, been promoted, appropriately so, to full professor. Congratulations, Dr. Wickwire. He is internationally recognized as an expert in sleep and sleep disorders, and he serves as section head of sleep medicine at the School of Medicine, where he oversees all sleep clinical, educational, and research efforts. Dr. Wickwire completed his advanced training in sleep at Johns Hopkins School of Medicine and later founded a leading interdisciplinary sleep medicine center that became a model for comprehensive sleep medicine centers throughout the country. Please keep in mind that Dr. Wickwire will be taking questions during the last 5 to 10 minutes of his presentations. Be sure to insert your questions in the chat box while the presentation is in session, and here to present on almost everything you'll ever need to know about sleep, Dr. Emerson Wickwire.
Thank you very much. It's a pleasure to be here with you, and that is a very timely update to my professional bio. I just received my formal notice from the dean today, so appreciate that. Okay, that's a very warm welcome. As was mentioned, I'm Dr. Emerson Wickwire, a biobehaviorally trained clinical psychologist by background, but really a sleep disorder specialist. And so I've been focusing in sleep medicine for the past 20 years. I always look forward to the mini med school. It's a wonderful opportunity to do some outreach, if you will, or in-reach for you, and sort of shake hands and get to know each other a bit. Because sleep is always such a popular topic and folks have so many questions about sleep, feel free to chime in with as many questions as you'd like. And certainly I'll circle around to those at the end of the presentation, but I want everyone to feel that this was a helpful and beneficial and enjoyable hour of your time. So we'll really focus on what you're interested in speaking about. Now I'm going to go ahead and share my screen. Can everyone see slides? Thumbs up? Okay, terrific. As was mentioned, we really have a three-pronged approach to sleep health at the university, and we work in close partnership with the University of Maryland Medical Center and the Midtown campus, and soon really the whole system. But we're housed in the School of Medicine, where we focus on patient care and clinical research and education. And some of that education is public education, as we are tonight, but we also educate medical professionals and medical trainees, really healthcare trainees at all levels in our institutional efforts. We have a broad team. These are some of my faculty colleagues. We're housed in the Division of Pulmonary Critical Care and Sleep Medicine, which is nested within the Department of Medicine, the largest department in the school. And then we also have wonderful nurse practitioner and support staff. So it really does take a village, and we have a very interdisciplinary approach. Now, tonight, in the context of an introductory presentation, I thought it would be helpful to focus on 3 of the topics that I'm asked the most about anytime I have a chance like this one to present to non-medical professionals. Those are really what sleep is, what sleep does, and what happens when sleep goes wrong. Now, before we get started, what I'd like you to do, you can post this in the chat if you'd like. In fact, let's go ahead and do that. We'll increase engagement a little bit. Please post in the chat one benefit that you would like to receive out of this presentation. So 45 minutes from now, when we wind down, what's one thing that you'd like to know that you don't know right now? One benefit. If you have a keyboard, go ahead and type that in to the chat function, please. And I appreciate the congratulations. Those are very kind. One benefit you'd like to receive. What's one thing you'd like to know when we're done that you don't know right now? This is one of those times where It would be great to have the Jeopardy music that I could play in the background. I'll give it another sec. Oh, why do people snore sometimes and other times they don't? Excellent. Thanks, Tara. We'll speak to that. Okay, here they come. How to get back to 8 hours of sleep. What qualifies as good sleep? What works best when awakening in the middle of the night and I can't sleep? How to improve on sleep during stressful times? How does interrupted sleep affect your health? Like if I can't get a full 4 to 6 hours? Well, that one I'll partially answer now because a full 4 to 6 hours is chronic sleep deprivation. That is not enough sleep. We'll talk more about that. What does good sleep mean? What happens when sleep goes wrong? How to get a good night's sleep? Excellent. Thanks everyone for chiming in. I'll do my best to speak to all of those questions. How to improve sleep quality? Okay, so these are the kinds of things that your peers and fellow classmates are interested in knowing. Now, sleep is, first, let's step way back. To understand sleep, we need to place sleep in context. And that is really the context of rhythm. Whoops. So currently it's fall, right? Here in Maryland, trees are starting to come down. Soon it's going to be winter. There will be snow on the ground. Next spring, there will the snow will start to melt and the flowers will poke through, and then we'll have summer, excuse me, and fall, and of course winter again. Each month there is a lunar rhythm. The moon opens and closes. You can think about the monthly rhythm of a woman's menstrual cycle, for example. Each day, the sun rises and sets in what we call a circadian rhythm. You've heard of carpe diem, seize the day. Our internal body clock is very similar. Circadian, circa diem, about a day. Now, our internal body clock, you may or may not know, doesn't function on a 24-hour clock. In fact, our internal clock is hardwired for adults. It's about 24.2 hours. And as we age, that what we call the circadian phase shortens some. So it moves closer to 24. But the reason that that's important is if you didn't have an alarm clock, you would sleep in later and later and later each consecutive day across the week because your body clock is slightly longer than the day clock. Now, we're going to talk more about rhythm, and particularly when we think about when sleep goes wrong, the implications of that rhythm being interrupted. Now, in the context of rhythm, sleep is the inverse or the opposite of the busy, active, engaging time of our day. You can think about your waking life being active and on, and sleep being a time to slow down. Our heart rate and blood pressure both decrease. Our respiratory rate, the number of times that we breathe per hour, diminishes. Our oxygen consumption slows down. It's really a time to rest and recharge. Now, a wonderful and influential sleep scientist from earlier in the 20th century at Harvard stated that sleep is of the brain, by the brain, and for the brain. So particularly as we age and we think about things like memory and cognitive function and dementia and Alzheimer's disease, the importance of sleep on the brain is increasingly recognized, and I'd like to talk about that for just a moment. So sleep takes place in rhythmic, organized stages. Across the night, our brain oscillates in and out of deeper and shallower stages of sleep. So you'll see here early in the night, this is when we have most of our what's called deep sleep or slow wave sleep, with only a short period of what's called rapid eye movement or REM sleep, which is when most, but not all, dreaming takes place. Now, the reason that this is important is slow wave sleep is when human growth hormone is secreted. And you've heard about human growth hormone or HGH because the professional ball players use it to build their muscles up. Human growth hormone keeps us physically young, and it's released specifically during slow wave sleep. So this is only speculative because these are correlational studies, but very clearly, sleep begins to get worse, human growth hormone secretion begins to decrease, and we biologically age. So it's speculative, but very possible that preserving healthy sleep is a fountain of youth of sorts. Now, at the same time, you'll notice that these red blocks get bigger and bigger later in the evening. This is because our periods of REM, or rapid eye movement sleep, get longer and longer. When you awaken in the morning, it's typically the dreams that you were having right before, right before you woke up that you remember. And the reason is because that period of REM sleep is the longest. Now, the next slide at first is going to look very busy. And what I want you to do at the beginning is only look at two lines, the line at the very top and the line at the very bottom. Okay, so ignore everything else. Only look at the line at the top and the line at the bottom. And what you'll see here is that when we are awake, the electrical activity in our brain is very fast and very low voltage. In other words, these lines are short and close together. What this line represents is the electrical activity in your brain. It's measured using a tool called an electroencephalogram, where electrodes are placed on the scalp and we can track the electrical activity in your brain. Now, remember, I said only look at the top and bottom lines. So here, when we're awake, we've got very short lines that are very close together. By contrast, when we look down here, I said the bottom, it's actually the next to bottom line. What you'll see is that these lines are very tall and much farther apart. This progression from wakefulness through drowsiness, stage 1 sleep, stage 2 sleep, and deep sleep, you're seeing here that the brain is slowing down. And that's exactly what happens across this cycle. So our brain waves slow down and our brain waves speed up, and our brain waves slow down and our brain waves speed up across the course of the evening. Each sleep stage is associated with a different function, emotional processing or physical restoration, for example. Now, when we measure sleep, generally there are three ways. The gold standard is for you to come and spend, I suppose we need to be careful with our language when I say for you to come and spend the night with us, but in a way that's true. What you do is you come to our accredited sleep disorder center and undergo what's called an overnight sleep study, or polysomnogram. Poly stands for many, somnos for sleep. And this is when we measure many physiologic functions during sleep: brain activity, respiration, respiratory effort, blood oxygen saturation, heart function, muscle tone, and so on and so forth. It's really the gold standard for diagnosing the majority of common clinical sleep disorders. Now, in addition to this intensive procedure, or more intensive procedure, it's outpatient, but you still have to come spend the night with us. We do our best to make it hotel-like, but it's a diagnostic test. We also use what are called actigraphs, which are the research grade or medical grade Fitbit or Apple Watch, for example. And finally, the most common and oftentimes incredibly helpful tool is simply what we call a sleep diary. And the sleep diary is just a log where each day you are going to write down, based on your memory, not based on staring at the clock, what time did you go to bed? How long did it take you to fall asleep? Did you wake up during the night? What time did you awaken this morning? Did you have caffeine or alcohol? Did you exercise? So on and so forth. And this is an incredibly useful, very cost-efficient tool to understand your sleep patterns. Let's talk a little bit about where sleep comes from. And I'm going to explain to you two hardwired biological processes that really drive the sleep system in our brains. The first of these is called the sleep drive, or the sleep homeostat, or sleep pressure. And as you can see in this slide, it increases over the course of the day, just like hunger or thirst. That wasn't a setup, by the way, but I am thirsty, so pardon me. The longer that we go without eating, the hungrier that we get. The longer that we go without drinking, the thirstier that we get. And it's just the same way with sleep. Now, the more active that we are, the more our body craves sleep. So if we're out running a marathon, for example, we will build up more sleep drive than if we're lying at home on the couch eating chips. Caloric expenditure will increase the accumulation of sleep pressure or sleep drive. Now, the one other factor is duration of wakefulness. The longer that we have been awake, the sleepier we will be. And the reason that this matters, particularly as we age, is that when I nap, my sleep pressure largely resets. So think about this. If I awaken at 8 in the morning and I typically go to bed at 10 o'clock at night, just as an example, that means that I've been awake 14 hours. Or let's say I awaken at 7 in the morning and I go to bed at midnight, okay, or 11. We'll say 12 to 7 for now. I've been awake 17 hours from 7 a.m. till midnight, or for you, from 7 a.m. to midnight. If I take a nap in the middle of the day from 3 to 4 in the afternoon, now at midnight, I've only been awake 8 hours instead of awake 17 hours. So this is one reason why in healthy sleepers, those of us without sleep disorders, naps can be wonderful and refreshing. But for people who are having trouble sleeping at night, we want to be very careful about napping, because napping during the day, depending on exactly what's happening with a given individual, can actually make it much harder to sleep at night. Now, if all that were happening was our brain was building up sleepiness, we'd conk over. We'd be pathologically sleepy all the time. So at the same time that our brain is building up sleepiness, it's also producing an alerting signal, a circadian alerting signal to keep us awake. Now, one thing that I want to highlight right here is that you'll notice in the early afternoon, there's a dip. This is why this ultradian dip, a within day dip, this is why you feel sleepy in the early afternoon. It's not because you had a big turkey sandwich with lunch. This is hardwired. It's the biological basis for the Spanish fiesta, where historically folks would go and take a nap from 1 to 3 during the heat of the day. Now, the second thing that I want to highlight is that there is no alerting signal in the middle of the night. And this is why shift workers are so much more prone to accidents and errors on the job. Now, you can see here how the sleep drive and the circadian alerting signal interact, okay? That as we're getting sleepier, we're also being more strongly kept awake. And then during the night, as we're sleeping, as our sleep drive is going down, our body is also producing less alerting signal. Interestingly, sometimes folks ask, well, doesn't this mean that right before bed, I'm also really wide awake? And the answer is yes. We have a young son, and for those of you who have had children or perhaps have grandchildren, you may remember that right before your grandkids go down, or right before your school-age kids go down at night, they're flying off the walls. It's not because they don't listen to us. It's because this is their body's most active time during the day, right before they nod off. Okay. The strongest regulator of circadian rhythm is light. And this is why, for those of you who have traveled to Los Angeles or London, after a few days, your body clock adjusts, because each morning, the light, your eyes are exposed to light at a different time of day, and that resets our circadian clock. It's also why it's very important to avoid bright lights close to bedtime, particularly bright lights from cell phones, from laptops, even from bright televisions. It's interesting, the strongest, or a very strong, shall we say, suppressor of melatonin. Now, most of you have heard of melatonin. It's a sleep-related hormone. It's not a sleeping pill. It's a sleep-related hormone that tells our brain it's dark outside. So as the sun is setting, our brain is secreting melatonin, and it lets our brain know that it sort of helps set the stage for sleep. And melatonin is very light sensitive, particularly sensitive to light in the blue spectrums. Now, light in the blue spectrums has two interesting properties. One, it increases what's called positive affect. In other words, it makes us happier. It feels good to look at things with blue light. The second is that it's very cheap to produce. So all of our digital devices emit very high levels of blue light, which is a very powerful melatonin suppressant. And this sort of explains why it can be really easy to get caught up in your cell phone, particularly as bedtime approaches. This photo is from a sleep study, from a pediatric sleep study. We wrote this paper a number of years ago, 5 or so years ago. And there was a girl who came in for an evaluation of a sleep disorder. She was 7 years old, and the technologists were watching her brain tracings and so forth, and went in to take a look at what was going on. And sure enough, she's glued to her mom's phone. Okay. The different stages of sleep that we've talked about are very, very different. Being awake, being in what's called non-REM sleep, and being in what's called REM, or rapid eye movement sleep. We don't have time to do a deep dive on the neurobiology and the neurophysiology of distinct sleep states, but your brain is far more sophisticated than you may realize, and these are mutually exclusive. It's not just sleep and wake. There are many more things that take place in between. So we've talked a little bit about what sleep is. Next, we're going to talk briefly about what sleep does. First thing I'm going to do is, I'm not sure how to bring up the chat box, but I'll bring up the chat box as soon as I
Let's talk about what sleep does.
No,
and when sleep goes wrong.
Thanks for that. Thanks for that. I was going to take a look in the chat here. So make sure that you put your questions into the chat. Okay, so we're going to focus, even though one of the questions earlier was on sleep and health, and I'm happy to speak to that. I'm going to focus in the short term on sleep and brain function, okay? So sleep impacts the way that we make moral decisions. And in fact, sleep-deprived bosses and sleep-deprived employees do not make the same quality moral and ethical leadership decisions when they're sleep deprived. Now, it gets even more interesting than that. The sleep deprived individual is unable to tell. But if the boss is sleep deprived, the boss thinks that they're getting away with it, or that they're performing just fine, but the employees actually tell that something is wrong. It's almost like being drunk. we humans are very bad at detecting when we are sleep deprived. Sleep is essential for learning. This is actually when neural networks are strengthened during sleep and unnecessary information is discarded from the brain. Sleep is vitally associated with the formation and retention of new memories. These are data from a very interesting study. There were 2 studies published in the same year, 20 years ago, actually. And I thought that this would highlight an interesting relationship between sleep and what we call neurocognitive performance or brain function. And what this y-axis or tall line on the graph represents is the number of mistakes that are made during a standardized research test called the psychomotor vigilance task, or the PVT. And in this study, it was a very difficult study to do. The researchers recruited individuals who spent 10 days in the sleep research laboratory, day and night. And each day they underwent a battery of tests, brain tests and memory tests, and they were asked about their mood and so on and so forth. It was a very, very tightly controlled experiment. And individuals were randomized to 3, 5, 7, or 9 hours of sleep. And so what you see here is that the group that was randomized to 3 hours of sleep, every day of the week, they kept making more and more and more mistakes. And the group that was randomized, to 5 hours of sleep, the group that was randomized to 5 hours of sleep, they kept making more and more and more mistakes, just not quite as severely. Now, these researchers had a very interesting approach. And if you think about times when you've been sleep deprived or had a week where you really didn't sleep very well, or even made some lifestyle choices, or you had a due date at work, whatever it might have been, and you knew that you were burning the candle, what did you think you would do to feel better? You thought, I'll make up for sleep this weekend. What we saw, though, what these researchers showed, was that even after 3 days of recovery sleep, they were still making far more mistakes than they were when they started. So we don't yet know how long it takes to make up for lost sleep, but we do know that a long weekend isn't enough, okay? Let's talk a little bit about when sleep goes wrong. And we're going to do this. I'm going to do this. Oh, here's another question. No problem to whoever unmuted. That's okay. Let's read a couple questions here. What happens when sleep goes wrong? How to improve sleep quality? Why do I feel tired if I sleep over a certain amount of hours? Is sleeping too much a thing? I need 10 hours, but my significant other can sleep 5 to 6 and be fine. What can you do to get a proper sleep when you wake up 2 or more times a night? Congratulations, and I love your glasses. Well, thank you very much. And then apologies, I accidentally unmuted. No sweat. It's something that we've learned in the pandemic. It happens to all of us, okay? So let me touch base on a few of these. I want to begin with a question that came up earlier in the chat that asked about snoring, all right? Why is it that I snore sometimes, or that people snore? Why is it that I have a friend who occasionally snores sometimes, but other times doesn't snore? Let's talk about what snoring is, okay? Some of you remember when you were a boy or a girl taking a blade of grass, putting it between your fingers and blowing, and it would make a whistle. And the reason that it would make a whistle is the same reason that reed instruments can make beautiful sounds. There's a lot of air moving through a small space, so anything that is not nailed down vibrates. Now, as we age, the muscles in our upper airway, in the back of our throat, our breathing apparatus, if you will, they age. Think about what think about what a typical 18-year-old looks like at the beach, and think about what a typical 65-year-old looks like at the beach. Our muscles change over time. They lose patency. Now, in the as far as snoring is concerned, what that means is that the space in the upper airway can get smaller. So during sleep, all of the muscles in the body, of course, relax. That's why we're lying down and not up and walking around. But the muscles in the upper airway can relax differentially. Now, as the airway collapses, I still need just as much oxygen as I did before, or almost as much oxygen as when I'm awake. So my body is still inhaling and my diaphragm is contracting, trying to pull that air in, but the space has gotten smaller. Okay. And when I exhale, I've still got just as much air in my lungs, but the space has gotten smaller. So just like that blade of grass or the reed instrument, when things vibrate, it makes a snoring noise. Okay. Now, if we were in person, which maybe someday we will be in the mini med school, and I asked for a show of hands, how many of us have ever spent the night with someone who snorted themselves awake? I'd ask you to raise your hand, and almost everyone in the room would raise their hand. You've spent the night in the same room with someone who was a loud snorer, and then they'd have breathing pauses, and it would be quiet, and you'd try and fall asleep, and you'd try and fall asleep, and you'd try and fall asleep, and then they'd snort really loudly. This is because they were having mini suffocations. These are signs of a sleep disorder called obstructive sleep apnea that some of you have heard of. Obstructive sleep apnea is highly treatable, but it's also very dangerous if left untreated. Untreated obstructive sleep apnea is associated with increased risk for virtually every negative health outcome that you can name, ranging from heart attack to stroke to cognitive decline and Alzheimer's disease and dementia, to obesity, to diabetes, to major depression, diminished quality of life, and on and on. Now, the reason that I mention this is first to answer the questions that were coming up in the chat regarding snoring. Snoring is not a sign of good sleep. It's a warning sign. And if you're snoring, particularly if you have high blood pressure or any health symptoms at all, really, you need to talk to your doctor because you may benefit from an evaluation of obstructive sleep apnea, okay? The only way we can diagnose obstructive sleep apnea is to have a sleep test, and you should talk to your doctor about it. And those are the kinds of things that we take care of in the University of Maryland Sleep Disorder Center. Now, let's move forward, and then I'll be happy to answer more questions. Let's talk about the most common sleep disorder. It's called insomnia. And what this means is trouble falling asleep, trouble staying asleep, waking up too early, or some combination of the above. Now, insomnia needs to be associated with a daytime consequence, even though you might not always be aware of what those consequences are. This can range the gamut, from things like difficulty concentrating, irritability, somatic bodily complaints like headaches or GI difficulty, other stress-related concerns, worry, depressed mood, fatigue, sleepiness, lethargy, not having as much get up and go, feeling snappier, taking things out on loved ones when you don't really mean to. All of these can be signs of insomnia, along with a broad range of mental health and medical conditions. Everything from depression to anxiety to trauma to cardiovascular disease, metabolic disease, and on and on. It's very common. In clinical practice, roughly half of patients are having trouble sleeping. And what these data show here from a nationally representative sample of 10,000 US adults in 2011 is that depending on the diagnostic criteria, somewhere between 4 and 22% of individuals are meeting diagnostic criteria for insomnia disorder at any given point in time. Now, I want to talk a little bit about where insomnia comes from in your brain. There are two places, two broad causes of insomnia. One has to do with an overactive stress system, an overactive cortex, that causes increased body temperature, increased heart rate, increased stress hormones. And the other has actually to do with the choices that all of us follow every day. Now, what these data are showing, I realize this might be a little bit confusing. So first, just look at the top panel, please. And what you'll see here is that the black lines, the black dots, and the hollow dots are really clearly separated. Now, the black dots represent sleeping brain waves, and the hollow dots represent waking brain waves. Okay, and what you'll notice here in the good sleepers is that during sleep, from the time they fall asleep, the sleeping part of the brain is on and the waking part of the brain is off. But when we look at individuals, what you see is the sleeping part of the brain is, well, you know, it started off and it was on, and and the waking part of the brain wakes up pretty fast. Okay, so one of the things that we see in insomnia is that the brain stays active. And sometimes patients are aware of that. My mind's racing and I can't fall asleep, or my body just feels awake. But other times they're not experiencing any of those symptoms. They just don't feel sleepy. Now, the hypothalamic pituitary adrenal axis is the body's stress system. That's this HPA activation. And what you're seeing here again is that our stress hormones are overly activated relative to non-insomnia patients. Insomnia patients demonstrate more stress hormones. Their brains are more active, and particularly their brains are more active in areas that are involved with emotion and fear. Okay, so I do a lot of work, for example, with the Department of Defense. You can think about alertness, novelty detection, emotion regulation. People with insomnia, or people who are having trouble sleeping, these are the centers of the brain that are so active. And particularly during COVID, it's a stressful time. To be alive on the earth is to inhale a certain degree of stress. And I think all of us over the last 20 months or so have inhaled a degree of stress that hopefully we won't be inhaling forever. Now, the history of Western medicine says that biology drives behavior. And when there's a behavioral concern, all we need to do is just tinker with some brain chemistry, perhaps, and everything's going to change downstream. In the last 30 years, 40 years, perhaps, the understanding has advanced significantly. It's one of the largest paradigm shifts in the way we understand health globally. In fact, if you look at where dollars are spent by the World Health per the World Health Organization data, what you see is that the majority of healthcare costs globally are spent on obesity, cardiovascular disease, and other conditions that have a high degree of prevention, things like smoking, for example. So behavior and biology are really a two-way street. And in addition to the overactivation that we just described from a physiologic standpoint, there's also a behavioral component to becoming a poor sleeper. Each of us brings a predisposing risk for trouble sleeping: personality, hardwiring, temperament. How do I manage stress? And then life comes along, might be an acute stressor like loss of a loved one, or medical illness, or job transition, et cetera. It might be a chronic stressor like a global pandemic, or doc, I'm not sure what caused it. It's just been getting worse over time. So what do? I begin to do things like try harder to sleep, sleep in on the weekends, start taking more and more sleeping pills. I get over-focused on sleep. So I'm going to take Dr. Wickwire a 5-year track of everything I've ever done that could influence my sleep, a 5-year graph rather. I can become over-focused or over-obsessed with sleep. And don't get me wrong, by taking naps, by sleeping in on the weekend, in the short term, those things feel great if you're having a problem. The problem is that when that original stressor dies down or goes away over time, it's really these compensatory behaviors that become a bigger and bigger part of the problem and keep us up here in the insomnia zone. So this is what behavioral treatments for insomnia are designed to do. It's really to eliminate those compensatory behaviors. What I tell my patients is that the problem is you've gotten a lot of practice at being a lousy sleeper, and you've really become quite good at it. So the solution is we need to retrain your body to sleep. Earlier, I mentioned that poor sleep can adversely impact mental health, metabolic conditions, heart conditions, brain conditions, neurodegeneration, and even death. Okay. Now, in terms of treatments, we know in the case of behavioral insomnia treatments that there's really no question that they work. 75% of patients have sustained benefit. They help patients with a very, very broad range of what we call comorbid conditions or other problems happening at the same time. Virtually every organization that's ever considered the issue has recommended behavioral treatments. And when patients come to see us, there's an assessment which involves an interview. Oftentimes it involves sleep testing if we suspect other sleep disorders or other conditions. We will collaboratively develop a treatment plan, and then treatment takes place typically over 3 to 6 months. Generally, for example, in my case, and now I see fewer patients than I used to, I see patients about once a month. That's fairly typical. Okay. So I'm happy to answer some questions, and it's such a pleasure to be with you. I think we're pretty good on sticking with our schedule. Let me stop sharing. And would you like the questions to be moderated, or how should we proceed?
Yes, Dr. Wickwire, feel free to, pull directly from the chat. Also, it's a sizable group. I feel like we can unmute and take turns if we rather ask our questions, just being respectful of whoever is speaking. So feel free to put your questions in the chat or unmute yourself and ask your questions. Looks like we have a question that came in the chat. I was wondering if a person could sleep well. What should a person do to get some good sleep?
So based on what we talked about today, there are really 2 essential steps. And the reason, by the way, I'm mildly distracted. We have an 8-year-old guest who might come say a quick hello. One of the things that I was going to highlight to everyone, since mom is out tonight, is that 8-year-olds sleep in pajamas. And we all want to develop a pre-sleep routine to help us wind down in the evening. The idea of when we change into our pajamas or nightgown is actually very, very important. We don't want to wear the same garb and have the same kinds of thoughts during our wake time and during our sleep time. So developing pre-sleep routine and maintaining a consistent schedule are very, very important. Now, what I want to highlight to you is that we spoke directly to those issues. All right, there isn't this isn't a quiz, obviously, but I want to help connect the dots and tie all this together. We talked about circadian rhythms. It is very important to maintain a consistent sleep-wake schedule. It's also very important to help calm your brain and body each night before sleep. And that's what the pre-sleep routine can help us do. So maintain a consistent sleep-wake schedule and help our brain and body wind down before sleep.
And then also it looks like Ms. Payne said, in addition to her question, mainly a person who has lupus. So I'm guessing some sort of discomfort from having some sort of autoimmune disease. Is your advice the same, or do you have any specific tips for people who may have a hard time getting comfortable or deal with pain throughout the night?
Yeah, thanks for that question. So the Mid-Atlantic Lupus Society is tuned into sleep, and my guess would be that they might have some lupus specific materials. I know that I spoke there probably 10 years ago, so it would be worth checking out lupus specific materials. You can check online or give them a call. I don't know if they put something together, but I know they were thinking about it. Now, pain and sleep have what we call a bidirectional relationship. In other words, the worse that I sleep, the more susceptible I am to pain. And at the same time, the more that I hurt, the harder it can be to sleep. The one thing that I want to highlight is when we have, whether it's lupus or any chronically painful condition, some of these same principles we want to apply not only to night versus day, but also to within the day itself. I would encourage anyone to plan his or her what we call rest and activity cycles. This is particularly helpful as we age. In other words, at age 85, you don't have the same energy levels during the day that you do at 45. So it's not realistic or even desirable to sort of wake up at 8 in the morning and plan on getting up and going until 8 at night at age 85. We can think about building in some peak times and some rest times even over the course of the day.
All right, thank you for that. And then we had another question that came in. Why do people drool while sleeping?
So earlier, when we talked about obstructive sleep apnea, one of the things that I wanted to clarify is that the upper airway can totally close. And we have these suffocations where I'm trying to breathe in, and eventually there's a loud snort when I'm trying to breathe in so hard that that breathing pause is broken. Now, we know that patients with obstructive sleep apnea become mouth breathers, okay? And that's because they're fighting this chronic suffocation during the night. So oftentimes when people are drooling at night, it's because they've become mouth breathers, perhaps because they have untreated obstructive sleep apnea, and and that results in some drool. I'm not suggesting that every mouth breather has obstructive sleep apnea, but I am suggesting that the majority of obstructive sleep apnea patients are mouth breathers.
Right. Moving to our next question. Is a consecutive 5 hours of sleep better than getting 3.5 or 1.5 hours at each time when you sleep? So I'm guessing a cat nap.
Yes, in general, today, most people would prefer to sleep in a solid block. However, interestingly, we evolved to be what are called biphasic sleepers. And before the Industrial Revolution, humans slept in 2 blocks, roughly 4.5 hours. Then there would be an hour, maybe 90 minutes awake, then roughly 4 to 4.5 hours. Interestingly, that wakefulness period in the middle of the night was just about the same length as a sleep cycle. Now, there are a few reasons for this, but the biggest one is before electricity, there wasn't all that much to do on the farm between 6 p.m. and 6 a.m. the next day. So people just had more time to sort of be in bed, and there was less hustle and bustle, and the night was a spiritual time. But you can, in fact, there was a wonderful book written by a historian at, I think, Virginia Tech, named Roger Eyrich. The book is called At Day's Close, and it's all about sleep through the ages. And it's really a very, very modern phenomenon where we sleep in a solid block. That being said, most people prefer a solid block. Now, to the person who asked about 3.5 hours followed by an hour and a half later, 5 hours is chronic sleep deprivation. And the number of people on the planet who require 5 hours of sleep would be rounded to 0, right? So whether it's 3.5 and 1.5 or 5, either way, I'd encourage you to be setting more time aside for sleep.
All right. Our next question, what causes severe night sweats while sleeping?
Well, that's a good question. I don't want to keep going back only to obstructive sleep apnea, but certainly night sweats can be associated with obstructive sleep apnea. And the reason is the increased effort to breathe during sleep. There are other conditions that can be associated with night sweats, for example, nightmares or traumatic nightmares, but certainly what we call OSA or obstructive sleep apnea is a big one.
Okay. Can a person drink something to help them sleep?
Sleepy time tea. It's a wonderful addition to the pre-sleep routine that I mentioned earlier, and certainly worth testing. It comes in multiple flavors. I don't own stock in sleepy time, but I've used it myself, and that might be a nice addition to your evening wind down.
All right. Why do people use BiPAP or CPAP equipment?
Remember that in obstructive sleep apnea, the problem is that there's not enough space in the upper airway for air to get through. So any solution to obstructive sleep apnea needs to increase space in the upper airway. And what BiPAP or CPAP does is it gently blows air to hold that upper airway open.
All right. How can I get a deeper sleep? I am a light sleeper, and the slightest thing can wake me up.
Sure. Number one, make sure that you feel safe in your home and bedroom environment. Number two, pick up an eye mask and comfortable pair of earplugs. Depending on where you live, or if you shop at Amazon or Walmart or Whole Foods, but buy an eye mask that's comfortable. It'll cost you probably $10, or you could certainly get one for less, but it's worth investing in one that's really comfy and makes you feel secure, and that's going to block out all the light from your eyes. We talked earlier about how important that is. The second thing is to buy comfortable earplugs, and earplugs come in 5 or 6 different styles, depending on if you want to buy 5 or 6 all at once or try them one by one. That's totally up to you. But remember that different parts of the brain can be more or less awake or asleep. So what we need to do is make sure that we've cut off all the sound that can enter our brain, or at least reduced it, because otherwise we might think we're asleep, but the part of our brain that's paying attention to noises is actually awake throughout the night.
All right, and it looks like Ms. Butler has a question. She wanted to unmute yourself. Ms. Butler, feel free to go ahead and ask.
Hi, good evening. Thank you so much for the presentation. So I have a quick question. So I track my sleep through an app. And so in the app, it tells you like how many hours you had of restful sleep and how many hours you had of light sleep. And I seem to be falling into the more of like the light sleep. I'll get like 7 hours of sleep a night, but falling into the lighter sleep. Like, how can I increase my more restful sleep, if that makes sense?
I understand. How do you feel when you awaken, and how do you feel throughout the day?
Oh, I'm tired. I'm sluggish. I'm definitely sluggish throughout the day. I get my pickup like probably at like 9 o'clock. I don't do caffeine. So it's just like a natural high I feel like that I have, but I still need more restful sleep.
9 p.m. or 9 a.m.?
9 a.m.
Huh. And what time do you go to bed?
I'm trying to pull my schedule back. I used to go to bed at 10:30, but I'm trying to go to bed more at like 9:30 because I get up by like 5.
So technically you're a shift worker, and I suspect the reason that you're now, obviously you're not my patient, and all the kinds of caveats that this is a presentation format, right?
Right.
So, but in general, if someone were to say to me, my Fitbit's telling me I'm getting 7 hours of sleep, I get out of bed before 5 o'clock every day, why am I so tired? I would say, one, you're a shift worker, and most people are going to be tired if they wake up at 5 a.m. The single most powerful thing to do is see if you can move that 7 hours of sleep to 8 hours of sleep and see if you feel better.
Thank you for that.
You're welcome.
Alrighty, and we're running a little short on time, so I think we have time for 2 more questions. I'm just going to randomly pull from the chat. I've tried to make sure that everyone has been able to ask at least one. question. Next question, is there research approximating when the wake period and 2 sleep periods are?
I'm sorry, I don't understand the question. Could you repeat?
It seems, okay, is there research approximating when the wake period and 2 sleep periods are? It looks like, is it Aisha who asked this question? If you want to unmute yourself.
Yeah, Aisha. So you were discussing how the natural sleep pattern of humans before the industrial period was to sleep for a certain time, to wake up and then go back to sleep for a certain time. I was wondering if there was research explaining like when exactly in the night that happened or when that wake period was.
Yeah, so that's a good question, and I can answer it at a high level, but I can't cite a specific study. Earlier, if you remember the sleep orchestra, the sleep rhythm slide that I showed, that shows our brain oscillating in and out of deeper and shallower stages of sleep over the course of the night. And I pointed out that each sleep cycle is about 100 minutes from peak to peak, okay? Our brain actually follows those same roughly 90 to 100 minute cycles always. So across the 24-hour period, our brain is following similar oscillations, even though obviously we're not sleeping in the middle of the day most of the time. Now, the reason that I mention that is the duration of that awakening between what was called first sleep and second sleep was about the same duration as a full sleep cycle, which makes sense based on what I just explained to you. Now, if I had to guess, the time when that between sleep, and there was a name for it, I just don't recall off the top of my head, would take place is probably going to be right about the middle of the night. Because if the sun went down at 7 p.m. and if the sun rose at 6 a.m., most people are going to have slept from about 8 till 6. So 8 till 6 is 10 hours. Take the 100 minutes in the middle, and that's probably a pretty good guess.
All right, thank you so much.
My pleasure.
All right, and Dr. Rickwire, do you have time for one more question?
Absolutely.
All right. So our final question for the evening, why do some people urinate on themselves when they are sleeping? Is that a sleep issue or a bladder issue?
So in general, we would not think about that being a primary sleep issue, although in severe cases, these kinds of issues have happened. If you're talking about children, what's called enuresis, certainly children, before they learn bladder control or sometimes associated with trauma, can urinate on themselves at night. And there are standardized, very effective behavioral treatments to solve this. But in the case of adults urinating on themselves, the first place that I go is primary care physician.
All right. All right. Well, Dr. Rickwire, thank you very much for spending a few extra minutes with us this evening to answer all of our questions. There were amazing questions in the chat. We tried to get to most questions tonight. However, please remember that this PowerPoint will be available tomorrow. So if you check the website tomorrow, you will be able to refer back to the PowerPoint. And I know that I believe there were some links. Did you include some links in your presentation, Dr. Rickwire, with some more information, or do you have any you could suggest that we could put in the chat?
Sure. Sleepeducation.com is the public-facing website of the American Academy of Sleep Medicine. And there will be lots of science-backed information and guidance. The National Sleep Foundation, their website is sleepfoundation.org. And the same thing, there will be very helpful information there as well. Let's give Ms. Robinson, if you want to unmute or give Ms. Robinson a thumbs up for emceeing and hosting us. Okay, it's always a really nice function, and I hope that everyone enjoys the next weeks of the course. thanks very much for having me, and I wish you a wonderful night, okay?
Awesome. Sounds great. Thank you so much for joining us. And thank you everyone for the kudos and for joining us this evening. If we could quickly take a minute just to look ahead to next week. Next week, we will be joined by Dr. Jeannie Law, who will be presenting on understanding common blood disorders. And then we will participate in an engaging panel discussion with three of our faculty presenters, Dr. Anik Forrester, Dr. Londette Jones, and Dr. Maureen Black. They will be serving as panelists. Our topic of discussion will be health equity and social justice. So we don't want to miss that. So please be sure to complete your course evaluation at the end of tonight. That was placed in the chat earlier during our intermission. However, I can place it in the chat as well so that it can be right at the bottom of the chat so you don't have to fish and scroll for it. All right, well, thank you so much for joining us. We look forward to seeing you next Tuesday. Have a great night. Good night.
Have a good evening. Thank
Thank
you.
you. Thank you.